All right, we are going to get started. Thanks everybody for attending. This is Project Echo, and we are Project PEPI actually. So, what PEPI stands for is Project Echo for Primary Immune Disorders. And what our goal is here at PEPI is to try to get as much education out there to kind of help other doctors or other people in healthcare, anyone really, to be able to take care of their patients and just give them more education. And so for today, we have Dr. Laurie Borsch. He is here and he's going to talk about mastering sinusitis. And his talk is a little long, so I'm going to let him just take over from here. If you have questions, feel free to interrupt. You can chat in the chat box. We want to hear from you, so ask as many questions if you like.
Okay, the floor is mine. So, as Andy just said, the title is How I Treat Sinusitis in the Immune Deficient. Quickly to start off with, it's important to always think of chronic sinusitis as, if you will, two different diseases. One is the infectious disease, especially in the immune deficient. And I'm going to talk more about this later on under antibiotics. But as with any humoral immune deficient condition, the biggest problem is the encapsulated bacteria, which can be pneumococcus, moraxella, or Haemophilus. And the sinus in particular, the sinuses love to grow staph. And in the immune deficient, we often get gram negatives. And then there's the inflammatory sinusitis, which is in a close, if you will, synergistic relationship with the infectious component, as I'll talk about in a moment. And inflammatory can be non-eosinophilic or eosinophilic. So this is the typical appearance of non-eosinophilic sinusitis. And what you should be seeing very clearly is this incredible glandular hypertrophy, lots of fibrosis, inflammatory cells that are mononuclear cells and neutrophils. And this is basically an inflammatory sinus disease. It's brought on, as I'll show in the next slide, by frequent episodes of acute bacterial sinusitis. These patients are less likely to get nasal polyposis. And the CT scans tend to look something like this, where air is black, bone is white, and you see a certain diffuse mucosal thickening through the maxillary sinuses, and there's completely opacified ethmoid sinus, but not as severe as what I'm going to show in a second with eosinophilic disease. And the model of this is that these are patients who are prone to frequent bacterial infections. The bacterial infections cause damage to the sinus tissue. The normal ciliated epithelial cells get denuded. They're replaced by goblet cells. The glandular hypertrophy that I showed a second ago, fibrosis occurs. This creates an environment where they're particularly prone to colonization of the sinuses with bacteria. I'm going to talk about biofilms later. You get this chronic purulent exudate. The purulence causes more damage and remodeling of the sinus tissue, which then promotes the further development of frequent acute sinusitis. But as I love to say, the airway is a stupid organ. And by and large, whether it's the sinuses or the lungs, the airways view all inflammatory insults as an attack by a worm. The perfect example of that is allergens, where basically allergic diseases is the human immune system looking at ragweed pollen or timothy pollen and thinking it's a worm, make an eosinophilic response. However, this is not an issue in the patients we're talking about today. I'll show you the data. These patients don't have allergies. The ability to have allergic reaction goes away. Cigarette smoke, not related to this talk, but 20 to 30% of smokers get an eosinophilic airway disease, which is why we're seeing recent approval of IL-5 targeting biologics in the treatment of COPD. The cystic fibrosis story is fascinating to me. I always assumed that everybody with CF had sinuses full of Pseudomonas and neutrophils, but when you actually look at the CF airway, about half of them get this eosinophilic airway disease, and when CF patients get nasal polyps, it's just like nasal polyps in an allergic person. They're bags of water filled with eosinophils, which is really surprising. And then there's the recurrent acute sinusitis. That is what's happening in these immune deficient patients, where you get this constant insult with bacteria, and the reflex response of the sinuses and the upper airway is to make an eosinophilic inflammatory response. And this is what that looks like. I don't need to point with my pointer here, but it's just as I said, a nasal polyp is just a bag of water just filled with these eosinophils. So this eosinophilic disease is, again, it's an inflammatory sinonasal disease. These patients are also getting frequent bacterial sinus infections, and it's the sinus infections that's triggering the eosinophilic inflammation. The eosinophilic disease is the one that is particularly associated with nasal polyposis, and their CT scans look more like this, where you see complete opacification here of the ethmoid sinuses and pretty near complete opacification of the maxillary sinuses. And that's the nasal polyp. This is not a precancerous or a cancerous condition. It's literally just herniation of inflammatory tissue out of the sinuses into the nasal airway. And as I said a moment ago, that's just a bag of water that's filled with eosinophils. So with that introduction, let me just sort of go through the various treatments, starting with what's really one of the best treatments we have, saltwater irrigation. The solution for pollution is dilution. So I was going through downtown Charlottesville a few years back, and I went to the historic bookstore, and I found this document. And as you can read, this is from the Department for the Cure, not treatment. Back in 1896, they were curing nasal catarrh and nasal polyps. So I couldn't stop myself from buying this to see how indeed they were curing nasal sinus disease, sinonasal disease. And here's the picture in the inside cover. And what I love about this is it actually hasn't changed in 130 years. Here's a large saltwater volume reservoir, and you have the saltwater coming down. It's going up one nostril, out the other, and into the basin. And honestly, the only thing that changes is that I personally don't recommend my patients wear a tuxedo when they do their saltwater washes, but I guess that could be an option. And here's another example of a large volume device delivering this drug called glycothylamine. Again, I don't think you have to do your hair or wear an old prom dress, but the technique is certainly not changed. And you sort of look at this and you see that whatever drug they were using could be used for any, and that's a term for mucus-producing conditions of pretty much any part of the body, including sinuses. And in 1896, like now, they had package inserts. So you all probably want to know what the active ingredient is in glycothylamine, and here you go, heroin. So the one comment I'll make is that, one of the biggest issues with saltwater washes is patient compliance. But in 1896, they really solved the problem of getting their patients to be compliant with this treatment. So saltwater washes, what we hand out to our patients are the Neilmed bottles. I think you're all familiar with them. There was a nice Cochrane review a few years back, and lots of studies, and they do show benefit, and there's certainly low risk, and the recommendation is large volume saltwater irrigation should be used. I think you're all familiar with this. The one thing we worry about is these amoeba that can cause amoebic brain abscesses. So in theory, you can use town water. Definitely do not use well water in Virginia, but by and large, we tend to recommend people use sterile water to make the saline mix. And here's an example of how this works. Put your thumb up if you can hear the sound. The language is Bulgarian, by the way, the Bulgarian player. And the blue shirt is the American. And there it is.
Итак, внимание, индийский спортсмен Патанджали уверенно берет в руки нетипот и пытается выйти.
What I can't get over is that there's actually an audience watching this competitive neti pot competition. There's the American not making our people very proud. Anyway, you got the gist of it. That is saltwater irrigation using a neti pot. Okay, what we don't use is antihistamines. As I said, this is not an allergic disease. They're not going to help. We also don't approve either systemic or obviously topical decongestions. They don't work and they're potentially harmful. Endoscopic sinus surgery. my quip comes on 2 slides. You cannot cure sinusitis with surgery. That speaks for itself. It's a chronic inflammatory disorder. It will usually invariably recur without lifelong medical therapy like the saltwater washes. On the other hand, very often you cannot cure sinusitis without surgery. The topical therapies that we're talking about have to be able to get in the sinuses. If you've got this huge nasal polyp sticking out of the maxillary sinus, all the salt water in the world, as I joke, the salt water will go into the healthy sinuses. It's not going to go into a sinus that's blocked by a large nasal polyp. So you need to have these large openings to put in not only salt water, but some of the other treatments I'm going to talk about. Plus, these treatments are all better at preventing the recurrence of sinus disease and polyps and getting rid of them. So sometimes just a good clean out to start things off and then doing lifelong medical therapy is the way to go. Corticosteroids are your best friend. Lots of studies show they work. They target that chronic inflammatory component. They prevent the recurrence of nasal polyps. They do prevent recurrent infections, and they can be given in combination with the salt water. So this is what I'm typically prescribing. It's the budesonide Respule. These things, of course, were designed for parents of young children who can't really use their asthma inhalers. So mom or dad sort of breaks off the tab there, pours the Pulmicort or budesonide into a nebulizer, and then administers the nebulized treatment to their child. In this case, you just break over the tab and you pour this 2 ml content into the Neilmed bottle and then do that irrigation once or twice a day. And you're using either the Neilmed bottle or a neti pot as a really great drug delivery device. In our studies, we can show that the saltwater washes do a great job in reducing the amount of inflammation in the sinus CT. Using a symptom scoring system, it reduces that. And for the patients who lose their sense of smell, it can often restore sense of smell. I won't go through this slide. It's basically showing the same thing, that budesonide, very effective in reducing inflammation and recurrent infections. So obviously the most important part in the immune deficient is the appropriate use of antibiotics. And I'll just start off by saying, again, that the most common bacteria in the immune deficient are these encapsulated bacteria, meaning specifically pneumococcus, Haemophilus, and Moraxella. Staph can be an issue, gram-negatives can be an issue. With the current resistance patterns in Virginia, azithromycin, that is the Z-Pak, really is no longer recommended. So we do not use the Z-Pak. Because Haemophilus and Moraxella are typically beta-lactamase positive, Augmentin is a great drug and it should be effective because of the presence of the clavulanic acid. On the other hand, pneumococcal resistance, which is becoming more and more prevalent, what it represents is competitive inhibition for the beta-lactam binding site, and that can usually be overcome with just a higher dose of the amoxicillin. So my treatment of choice for my immune deficient patients, we're just calling and saying, Doc, I have another bacterial infection. And if they're immune deficient, they're probably right. It probably is bacterial. I give both amoxicillin at the dose shown here and Augmentin. So the clavulanic acid takes care of Haemophilus and Moraxella. And with that combination, you're giving about 3 grams of amoxicillin a day. And that dose is usually adequate to deal with the pneumococcal issue. And I invariably get a phone call from the pharmacy saying, don't you realize that there's amoxicillin in the Augmentin? And the answer is, yes, I do realize that, but I'm going for a high dose. Now, one of the issues with the recurrent infections is that may reflect the development of a biofilm in the sinuses. And as I'm sure you all know, a biofilm is defined as the structured community of bacterial cells in a self-produced polymeric matrix and adherent to an inert foreign body, not true here, but adherent to the living surface of the sinuses. And there's sort of a sketch of what a biofilm tower might look like. And this is actually a nice scanning electron microscopy of a biofilm on a living person's sinus tissue. And bacteria, as you know, love to live in biofilms and survive. When they're in there, they successfully evade neutrophil or complement-mediated cytotoxicity. The neutrophils are constantly degranulating by this frustrated process. And of course, as they release all their digestive enzymes and the oxidative process, that's causing a lot of the collateral damage in the adjacent tissue of the sinuses. And again, creates that environment that promotes biofilm formation and recurrent infections. And again, I think you all know bacteria in biofilms display decreased susceptibility to antibiotics. Indeed, a bacteria in a biofilm can survive treatment from 100 times to 1,000 times the predicted inhibitory concentration of an antibiotic. Typically, when you have a biofilm on, say, a foreign body, like a hip implant, you just have to remove the foreign surface. Obviously, you can't do that at the sinuses. So the way we deal with biofilms in the sinuses is with soap, specifically a surfactant. And these are substances that naturally debride the biofilm off the surface. And my favorite soap is nothing other than Johnson's baby shampoo. And I'm not going to read all this content here, but I'll show you the next slide that it works. But baby shampoo works really well. Another one that works really well is just the artificial sweetener xylose. Xylose can be purchased online from Amazon or wherever, and just a pack of xylose or 6 drops of baby shampoo in the saltwater irrigation works really effectively. And that's sort of shown here, where you see the biofilm on the far left, and then after a day or two with the surfactant, you just sort of see that the bacteria get washed away. And patients always look at me weirdly when I recommend the shampoo. I reassure them that their face isn't going to blow bubbles when they sneeze. That won't happen. But what they will see, then they'll find very rewarding, is that after the baby shampoo, the sinuses will just ooze out this sort of mucopurulent discharge, and that's a good sign that you're defeating the biofilm. Last comment is, you've used the salt water, you've used what you think is an appropriate antibiotic, and then the patient's back a month later with yet another bacterial infection. What do you do then? And my answer is, find an otolaryngologist and make that him or her your new best friend, because at that point with the recurrent infections, you really have to know what you're treating. You presumably dealt with what you thought were encapsulated organisms, but as I said, it can be staph, it can be gram-negatives, and what works is an endoscopic guided culture, meaning an trained otolaryngologist going in there with a scope can place the swab right on top of the pus that's pouring out of the sinuses, and that culture is meaningful. Our blindly putting a culture swab in somebody's nose is proven ineffective for really identifying the actual relevant bacteria. And once you know what you're treating, if you're really dealing with recurrent infections, along with the surfactant, we will often put the relevant antibiotic in the saltwater solution. So if it's staph or gram-negatives, an aminoglycoside, tobramycin is a perfectly reasonable one to put in the saltwater solution. A gram-negative quinolone like ciprofloxacin for gram-negatives. For staph, my favorite one is mupirocin. It does not work, obviously, for Pseudomonas because mupirocin is actually grown from the Pseudomonas bacteria. It's an oily thing. It's hard to get a solution, but it's remarkably effective for staph infections. And again, you can't just stick it in your nose the way you would be using to treat colonized staph. It goes in the salt water bottle, into the neti pot or whatever, because you're basically using that salt water as a drug delivery device to get the salt water with the mupirocin or other antibiotic into the sinuses. And the last part of the talk is really just the role for biologics. And there are 3 now biologics that are approved for treating sinusitis. Let me just start by mentioning omalizumab, because that is the only one that you won't use. There is no IgE, or virtually no IgE, in individuals with humoral immune deficiency. This is a study that I did with my colleague, Monica Lawrence, looking at IgE in immune deficient. The Olin is a Norwegian control cohort that just sort of shows the range of IgE that can be seen in healthy people. And the takeaway message is that Absence of IgE is pretty rare in healthy individuals, although it does happen. In contrast, this is the UVA CVID cohort. This is a national network of immune deficient patients. And what you see is anywhere from 52 to 74% have no IgE. And if you include the people with vanishingly low IgE, it's close to 90% of patients just don't have IgE in these disorders. So if they don't have IgE, anti-IgE is obviously not going to be helpful. The other point, this is not related to specifically treating sinusitis, but I think it's just important to point out, if there's no IgE, these patients can't have allergies, despite what they think. Pollution, molds in the airway, they can certainly act as airway irritants. Obviously, on a day when the wind is blowing from the Ohio smokestacks, people will have runny, irritated noses, but it's not allergies. It's not an IgE or mast cell disorder. And there's, again, no role for antihistamines for these patients. IL-5, what's approved for this disease is mepolizumab. IL-5 is, of course, the most important eosinophil hematopoietin. In English, what that means is if you take stem cells from the bone marrow and grow them for 2 weeks in the presence of IL-5, at the end of the 2 weeks, what you get is pure populations of eosinophils. It also keeps them alive. Eosinophils normally can only live a day or two. With IL-5, in the test tube at least, I can keep eosinophils alive for almost a month. And of course, it's chemotactic and priming and everything eosinophils, they do worse in the presence of IL-5. This is a real old study with anti-IL-5. These are not in immune deficient patients, but I love showing this study because it really points to how a lot of these biologics behave in the real world. What the pharmaceutical industry loves to publish is our data like this that just sort of shows that, yes, there's significant reduction in polyp size. I love this study because it shows you the 10 or 15 individuals in the study and what actually happens, which is half of them do really well, and half of them may as well be getting a placebo. And I think that tends to be what our experience is. I don't know how to predict who the responders are, although the obvious answer, and I alluded to it earlier, is the ones with an eosinophilic disease do well, and the ones with a non-eosinophilic disease perhaps don't. And then the last drug that FDA has approved for this, for sinusitis disease of polyp, is dupilumab. And again, another study showing that with the dupilumab, the polyps disappear. I love the term SNOT-22. That is the Sino-Nasal Outcome Test. It's a 22-question questionnaire on how patients are doing. And it does show that dupilumab greatly improves the sinus symptoms, and as I showed a moment ago, reduces polyp size. But this is my next to last slide. Cost considerations. This is the omalizumab cost was from 2020 when Genentech realizes that everyone else is charging twice as much. They immediately responded by doubling their price. So at this point, omalizumab is not a bargain. And these drugs are, and this is the monthly wholesale cost. So you can imagine what a $3,000 a month drug costs. Retail multiplied times 12. I mean, these are ridiculously expensive drugs, but every now and then when we've tried all the other treatments, it's what we have to turn to. So my last slide, I laugh because the joke that I often tell patients is that they come to UVA and they want me to give them a respirable antisense oligonucleotide IL-5 antagonist, and what they leave with is a brand new clean Neilmed bottle. Large volume salt water treatments is really your best approach. I recommend mucoevacuants, guaifenesin. I don't know how helpful they are. I talked about sinus surgery. If there's large polyps, you're not going to fix the disease with saltwater irrigation. Make a surgeon your best friend. Steroids in the saltwater bottle. You don't want to be using them systemically in the immune deficient. Can reduce infections, reduce inflammation, eradicate the polyps. Antibiotics, the way I mentioned my recommendations there. For refractory disease, if possible, get an endoscopic directed culture. And for the people who are really refractory with all that, we will consider the use of biologics. And that is my last slide. And I believe I've left about 4 or 5 minutes for questions if people have any.
Does anybody have any questions?
Larry, great talk. Anyone that can work the term zwitterion into an immunology talk is a friend of mine, as someone who's a chemistry major in a former life, especially a biochem major. So yeah, this was really helpful. We think a lot about sinus disease in the context of antibody deficiency, which makes a lot of sense, right? I mean, you don't make antibody sufficiently, you require antibody immunoglobulin replacement therapy, which kind of plugs the dam, if you will, a hole in the dam, and then the person potentially can go on to have, improved sinus health anyway. Your talk made me think not only about that, but more about the expanding universe of inborn errors of immunity that, really present with immune dysregulation. So do you think sinus disease is a clinical harbinger of, or sign of immune dysregulation? And just curious about your thoughts on the number and kind of proportion of IEIs that have an immune dysregulation component that involve the sinuses.
I'm smiling because how do you deal with a 1 or 2-year-old child who has snot coming out of their nose 10 months of the year and distinguish the immune deficient from this is what kids do at that age? They're viral factories. And it's a real problem. What you don't see in children, of course, is nasal polyp formation. And to me, that's a red flag that there is something severely wrong with their immune system. But I don't know if you have a better answer than I do, just because of the problem of distinguishing a continuously sick child from one with an IDI.
Yeah. No, I mean, I think it's interesting to actually, this kind of, I think raises a question about an epidemiologic study where we could actually look at the proportion and kind of features of sinus disease across the spectrum of inborn errors of immunity, and just trying to understand what types of sinus disease different subtypes of IEI patients suffer from. Because I do think the antibody deficiency patients are going to be more likely to maybe just have, chronic bacterial infections and maybe not need a biological agent, but then there might be conditions like APDS or CTLA4, haploinsufficiency, et cetera, you name it, DOC8 deficiency syndrome, where, perhaps there's more of an eosinophilic infiltrate, and that is cells that are, in a place where they shouldn't be, kind of masquerading as atopy, but they're not atopic. It's not that they're atopic, it's that they're immune dysregulated. And in those individuals, it may be that a biological therapy is exactly what we need for them. So I think it's a really important topic, and that the phenotypes of sinusitis, as you articulated beautifully, actually make a huge difference potentially.
The bigger issue, and there's a couple comments in the chat. I was smiling because I was reading the chat box. Sorry, Tia.
Baby shampoo is your friend.
Yeah.
Honestly, that's great information. Thank you.
Yeah, obviously a lot of what I said is relevant to you and your chronic sinusitis patients. Honestly, the biggest problem I see in the world of the immune deficient is people focus too much on the lungs. And, they're treating the bronchitis and pneumonia, and that's what's triggering the workup. And they're ignoring the fact that people are miserable from their sinus disease, and it's destroying their quality of life. But it's also damaging the lungs, because I think there's an awful lot of that stuff in the sinuses is draining into the lungs. And some of the treatments we have, especially immunoglobulin replacement therapy, does a wonderful job for preventing pneumonia. But I think for the sinus disease, the problem with IgG is it's not IgA. And we're not putting the immunoglobulin where it needs to be, which is in the sinus secretions. And a lot of times patients are doing great, and we think they're doing great. No pneumonia last year, but when you ask, the sinuses are still a mess. And it drives me crazy because, the manufacturers are throwing all that IgA in the trash can. And I'm saying, no, give it to me. Because you could put anything in a Neomed bottle, right? Shampoo, Purison, IgA.
All right, it looks like we are about out of time, but Larry, that was fantastic. I still have the guys lined up to the neti pots in my head. Just I never knew that was a competition, but that was a great talk. I'm going to put a link in the chat box. If you guys can take just a moment. I know everybody's busy, but take a moment
Oh,
and fill this
did I
out.
mention that the use of heroin is considered off-label?
You did not, but that's good to know.
Sorry.
No, we're good. Just take an opportunity to fill out the survey link for us. We would like to know what we're doing good at and what we can improve on. And I'm also going to put our email in here. If you have any questions, please email us. If you have any topics you'd like us to cover, please let us know. We have the information and we want to make it readily available for you. So,
I'm putting a plug for next week because we're going to be doing a couple of sessions on vaccines, and
oh yes,
vaccines are very controversial, and we would love to have a real back and forth and answer the questions you think are important in dealing with your patients who may have questions about vaccine safety.
yes, that is the 18th.
I think it's, hold on, I'll know very quickly. Actually, it's next Tuesday.
Next Tuesday, yes,
Yeah.
we are
Yep.
going to have a board panel where Dr. Larry Borsch, Monica Lawrence, and Dr. Nick Ryder are just going to answer any questions that you have, especially if you have patients with immune deficiency and you have questions about giving vaccines to them or giving vaccines to them and having family members getting vaccines. Just any questions that you have around that topic, bring them. We want to answer them for you. And I think that's it.
All right, thank you all. Thanks for attending.
All right, thank you for attending. We'll see you in 2 weeks.